Welcome to the Essential Substance Abuse webinar series. I am Kate Trans and I will be administering today's webinar. Today, Robert Foley will be speaking on client, family, and community education. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the states served by each of the regional ATTCs. To learn more about our center, the network, or your regional center, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. We recommend that if you are preparing for an exam, that you seek additional preparatory help, and let this course be one of many tools you use to prepare. Our next webinar in this series is scheduled for Wednesday, January 22, where Ken Winters will present The Science of Addiction, the Brain on Adolescence. In addition to this webinar series, we offer another series titled the American Indian and Alaska Native Behavioral Health Webinar Series, which presents on current topics of interest in the behavioral health field. The next session in this series will be held on January 8th from 1 to 2 p.m. Eastern Time, where Aaron Bailey and Josie Rafaelito of the Center for Native American Youth at the Aspen Institute will present on Bereavement and Grief. What are the resources related to Native American youth? For more information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs. The cost is $10 to do so. The CEU request form, along with a copy of the PowerPoint, will be sent to you within 24 hours of today's session. If you don't receive the email with handouts within 2 business days, please let us know. In addition to the PowerPoint handout and CEU request form, a link to our GIPRA evaluation will be included in the email you received following today's webinar. We invite you to participate in this brief online customer survey. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GIPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. SAMHSA uses information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you will assist us in gathering information about our services by participating in our evaluation. Before we start today's session, I'd like to give you a quick overview of the GoToWebinar system. To hide or expand your toolbar at any time, you can click on the red arrow in the top right side of your window. To expand your screen, click the middle button in the top right-hand corner. You will be muted for the duration of this webinar. Please use the question chat box to share your questions and comments. Your questions will be only visible to me, the webinar moderator. I will pass your questions along to the presenter at appropriate points in the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEUs received. Today's speaker is Robert Foley. Mr. Foley has worked in various aspects of the prevention field for the past 11 years, including positions in drug and alcohol use, HIV, STI, and intimate partner violence, being named by POZ magazine as one of America's 100 most influential AIDS activists in 2010. Mr. Foley works as an independent consultant and was previously the president and CEO of the National Native American AIDS Prevention Center. Please join me in welcoming Mr. Foley.
Thank you so much. I hope everybody's doing well today and that December is settling nicely and everyone's looking forward to the holidays and the impending new year. I would like to thank Kate for inviting me to participate on this webinar today. This will be the third time I have participated in this particular webinar series, and I hope that everybody finds it useful. On the screen are the goals and objectives for this particular webinar, and I'm not going to move through these verbatim as you can see them. But we are going to be talking about the basics of some common infectious diseases, including sexually transmitted infections. We're going to talk a little bit about the theory of prevention and spend some time discussing and presenting on how we can apply this information and this knowledge to particular substance use prevention and treatment services. So in this day and age of integrated services, I think it's important for substance use service providers to understand all of this information regarding HIV, AIDS, and STIs, to know how they can work with their clients and clientele who might be at increased risk, how they can identify increased risk, and how they can assist with providing additional services or connecting their high-risk clientele to additional services. Under the required SAMHSA core competencies, this particular webinar will be addressing competencies 105 and 106, seeking to understand and describe the health and behavior problems related to substance use that includes the transmission and prevention of HIV and other sexually transmitted and infectious diseases, as well as looking at some of the principles and philosophies of prevention, treatment, and recovery. There are many objectives contained therein under each of these competencies, and as there are so many and so varied, I'm not going to go into each particular one, but we will be talking about some risk factors, prevention and transmission, the importance of prevention and transmission, and the validity of prevention and treatment. So I'm just going to jump right into the mix. We're going to start with a review of some of the dominant infectious diseases that we see here in this country, including HIV, chlamydia, gonorrhea, syphilis, a quick look at herpes, simplex virus, and then hepatitis A, B, and C. And this is not going to be a thorough HIV 101. Now, this is going to be more of a review for the disease, as I'm sure many people on this webinar have studied or learned about HIV in one way, shape, form, or another. And for those who have not, then hopefully they'll find this a useful introduction to the HIV disease. So when we look at the statistics of HIV in the United States, we know that more people are living with HIV than ever. The CDC believes that more than 1.1 million people are currently living with HIV in the United States, and that number increases by approximately 50,000 new infections each year. And so when we look at the simple math, there's a core number of people living with HIV, 50,000 new people are added to that base each year, and because of treatment and new technologies, those people are living longer. So we have an increasingly larger pool of people living with HIV each year. And because there's an increasingly larger pool, that increases the risk of transmission. And that's why even in this day and age where we do have advanced treatment and people are not passing away as quickly as they had in the past, it's why we still need to be talking about HIV and still need to be focusing in on HIV from a preventative perspective. In 2010, a little over 47,000 people were diagnosed with HIV, and that's just within 46 states. So that's why the CDC estimates somewhere between 50 and 51 or 55,000 even each year. The burden of new infections still lies primarily with men, particularly men who have sex with men. They account for, or men in general account for 3/4 of new infections annually, and women generally account for 1/4. And amongst women, heterosexual transmission is still the most common risk behavior. Thankfully, children account for less than 1% of new HIV infections. And that is one of the most successful, well, that's a success story when it comes to HIV, has been the reduction in mother-to-child transmission and childhood HIV. HIV stands for the human immunodeficiency virus. A couple misconceptions that we actually still hear about HIV is, can it be transmitted from a bug or a dog or a cat? People have read about its roots, the roots of the virus being in apes and chimpanzees. And so there's a lot of confusion. And so in the label itself, in the description of the acronym, human immunodeficiency virus, lies some very, very significant points that help actually explain to people the nature of the virus. It is human only. It cannot be transmitted from a mosquito or through a mosquito. It cannot be given to a dog or a cat or received from a dog or a cat. This virus can only survive within human beings. Immunodeficiency. This virus infiltrates the white blood cells within our body, specifically our CD4 T cells. Those particular T cells are responsible for attacking new infections or new antigens in our body. And so HIV is insidious in that it attacks our very defense system. And so by weakening our defense system, people living with HIV then become significantly immunocompromised. And it is, of course, a virus. And HIV is the virus that causes AIDS. And for the sake of simplicity, when I'm providing education, I just tell people that HIV is the virus and AIDS is a resulting disease of that virus. So people are living with HIV, and when HIV attacks their body to such an extent, then a doctor will diagnose them with AIDS disease. But it is this particular virus that is transmitted. Right? So you don't transmit AIDS, you transmit HIV, all right, the viral agent. Transmission of HIV occurs through bodily fluids, of which there are only 4 that account for significant transmission agents. It includes blood, semen, vaginal fluid, and breast milk. A lot of people ask about sweat, and a lot of people ask about saliva, and neither of those have been shown as effective transmission agents. And so there are only 4 that we focus in on: blood, semen, vaginal fluid, and breast milk. And on the screen, those 4 fluids are listed in order of their effectiveness. Blood is the most effective transmission route, semen second, vaginal fluid third, breast milk fourth. That is to say, more components of the virus, more viruses appear in a milliliter of blood than semen, and then in more in a milliliter of semen than vaginal fluid, and so on and so forth. So again, when we're talking about education and what to communicate to community members or people we're providing treatment to, we can talk about the 4 fluids, and I think that's an important piece of communication, but even more so are the behaviors that allow those fluids to transmit from one body to another. And that's why in our prevention and intervention activities, we focus more on risk behaviors. The most common being sex without a barrier, or sex without a condom, or unprotected sex, or sharing previously used needles or works. We are lucky to say that in the United States, we've almost eliminated occupational exposure, so that's exposure for health workers. Contaminated blood products, so we don't see any significant amount of HIV being transmitted through blood transfusions. And mother-to-child transmission, whether that's through the birthing process or through prenatal or breastfeeding. Once an individual is infected with HIV, there is a sequence of events. And it starts with acute infection. And this obviously begins with viral transmission once the virus has entered this particular person's body and has infected a CD4 cell. Once a CD4 cell is infected, it turns into a HIV factory, producing more viral copies, ultimately destroying the cell, bursting open, and releasing more virus into the body to seek out and infect additional CD4 cells. Acute infection lasts from days anywhere up to 7 weeks after initial infection. Generally marked by flu-like symptoms, a sore throat, a rash on the trunk of the body, night sweats, fever, fatigue, and massive viremia is happening biologically. So internally, there is massive viral reproduction going on. But those flu-like symptoms are so extremely common. You know, many people will go through fatigue and never see a doctor. Many people will experience a sore throat and go to the pharmacy for an over-the-counter treatment and again, never see a doctor or never think that they might be experiencing acute HIV infection. For that reason, a lot of people move through acute HIV infection without being diagnosed because these symptoms are so common and so shared amongst other conditions, common conditions. Excuse me. Acute infection resolves itself. So these symptoms will resolve themselves. Again, the symptoms itself will probably only last maybe about a week after their onset. Resolve themselves, people will begin to feel healthy again. And then they move into what's called asymptomatic infection. Obviously, they're not showing any of those outward symptoms like a sore throat or rash. The virus is continuing to copy at a slower pace. At this point, the body has learned what it needs to do to more effectively fight the HIV virus, and our bodies can fight and battle the HIV virus. Right? We've seen that. That's why asymptomatic infection can last anywhere from 2 to 12 years. But it's marked by a significant internal battle between our body's immune system and the virus. So the virus is persistently replicating, and at this point in our time, especially without treatment assistance, there is a gradual depletion of CD4 T cells within our body. So it's not so much of a stalemate. HIV continues to edge out our body, and within time, our CD4 cell count within our cells depletes at such a point that our bodies are no longer able to battle off more common infections. And we begin to develop opportunistic infections. It's at this point when our CD4 cell count drops below a certain level and/or we develop certain infections such as these listed on the screen that a person is diagnosed with AIDS. These opportunistic infections can range. They can be thrush in the mouth, oral hairy leukoplakia, toxoplasmosis, NAC, CMV. These are all fairly rare infections for the most part, except in those who are immunocompromised. This slide details at what point in our CD4 depletion will or is it more likely to see certain opportunistic infections. So Candida is generally the first opportunistic infection, thrush in the mouth, possibly Herpes simplex, especially if it's been living within the body for a while, will become active when a cell count depletes below 400. Shingles, PCP, which is a form of pneumonia, and so on and so forth. If the speed of this train is represented by the viral load, oh, let me try and go back there. Actually, we'll skip that slide. There's going to be a number of different lines that appear on this graphic. As we move from the left to the right, this is in advance of time, and you'll see, so over time, this purple line represents the viral load in the blood, and that's tend to be where we take our viral load measurements, is through a blood sample. You'll see initially that there's a spike in the number of viruses or viremia in the blood, and so during acute infection, people have the largest number of viruses in their blood, as well as other bodily fluids, and that's actually when people are the most infectious. Our body then learns to adjust, learns what it needs to do to battle. There's a drop in the viral copies, and so this is asymptomatic infection during this time. But over time, we see it, HIV will win that battle, and when the virus starts to replicate and win out over our own internal immune systems, that's when an AIDS diagnosis is delivered. And you'll see that this is indirectly related to our CD4 T cell count. So as the CD4 T cell count is depleted, the virus rises. Our bodies do produce antibodies. All right, that's our natural immunoresponse to any antigen. And so our antibodies do battle the HIV virus. And you'll see after initial infection, our body's producing more and more and more antibodies. And so it's doing what it can to battle the virus internally. And our antibody level remains stable throughout asymptomatic infection. And it's actually our antibody level that an HIV rapid test seeks to measure. So when antibody levels are so low, an antibody test will not be able to, is not sensitive enough to be able to register. That's why we have what we call a window period, where an antibody test may not be able to pick up HIV infection until 3 to 4 weeks after initial infection. New tests are more sensitive and could go, they say, even down to 1 or 2 weeks after infection. But since they measure antibody, we have to wait for our own bodies to produce enough antibodies for a test to pick up. And so I did want to talk a little bit about testing, because testing is currently a cornerstone, not just of our prevention approach, but also of our prevention policy. We see more and more monies and initiatives being pushed towards testing, and that's increasing testing to at-risk populations, increasing testing in non-clinical settings, and normalizing testing for the general population. There are a number of different clinical tests, but I really just wanted to talk about those that are most accessible by general community members, and that is rapid antibody testing. And I just talked about the antibody test, not actually testing for the presence of the virus, but for the presence of HIV antibodies, of which the production is triggered by the presence of the virus. So in antibody testing, there are a number of different companies that produce competitive, rapid antibody tests that will deliver results using a blood or oral sample between 1 minute and up to 20 minutes. The cost of the test can vary depending on different deals that are struck, depending on which test is purchased. But the test can really range anywhere from $9 to $15. Traditional testing tends to refer to what we call the Western blot, which seeks to identify the genome of the HIV virus. Processing a Western blot test can take up to 2 weeks. And as more specific and accurate tests are coming out, we're actually seeing the Western blot not being conducted as often because it is an expensive test and it does take longer. At the community level, most people are getting their HIV test results through rapid tests. Rapid tests can be delivered in non-clinical settings and in non-laboratory settings by institutes with a CLIA waiver, including many substance use prevention and treatment programs. A new technology that is really gaining ground are home tests, and these were just recently approved by the FDA. People can purchase a home test at any drugstore or pharmacy, including Walgreens or CVS, Walmart pharmacy, Kroger's, King Soopers pharmacy, any grocery store pharmacy. Prices range depending on the company produced. It could be $45 or $50, could be cheaper. People bring the test home, samples are collected by the individual, and there's depending on the test, it could be an oral or it could be a blood drop. And those samples are then mailed into the company, processed, results are delivered via the phone or via the internet. This is a wonderful methodology, that can be used by people who don't trust their healthcare system or fear for their own confidentiality or experiencing stigma in such a way that they're just paralyzed and preventing them from going into a clinical or aid service organization or for accessing treatment or testing in any setting. However, there are still some preventative cautions that need to be taken into account when administering or supporting home testing, and that is the counseling or the support that generally goes along with any testing procedure. If somebody with a home test receives a reactive test, what services are going to be provided to them in order to, 1, link them to a confirmatory test, 2, ultimately link them to the care, but 3, and what I believe is most important, providing the behavioral support and emotional support that they might need. The home tests there are 1-800 counseling numbers, counseling lines that are provided with the home tests, but there's nothing requiring, obviously, those individuals to access that support. So I believe that the home test is a wonderful advance in our technology and will increase access, obviously, to testing, but I do believe that we need to do a little bit more as service providers to ensure that those that are using this service have the full array of services that they might need. At the organizational level, the cost for an HIV test can be prohibitive. Whereas $9 to $15 does sound like a lot, when we're using other diagnostic tests that may cost up to $300. But when we're seeking to test, within any given year, 1,000, 3,000, 4,000 people, and then those numbers do add up. I will say that the cost of antibody rapid test has significantly decreased within the last 6 years because of the competition now on the market. So for better or worse, capitalism has done something right in the HIV world. It is now recommended that everybody between the ages of 13 and 64 receive an HIV test at least once in their lives, and those engaging in higher risk behavior be tested regularly. This is a significant recommendation And this comes not just from the Preventative Services Task Force, but also from the CDC, and is endorsed by SAMHSA, is endorsed by Indian Health Service, is endorsed by HRSA, the Office of Women's Health, and the Office of Minority Health. So all the primary funders and supporters of HIV services at the federal level stand behind this recommendation. Operationalizing this recommendation is where the challenge exists. Working with service providers in all sectors, whether it be substance use, other areas of behavioral health, teen pregnancy, reproductive health, adolescent health, OBGYN, and even geriatric health, that there is validity in this recommendation. You know, I've been speaking to groups, and I can now firmly say that yes, people over the age of 60 are having sex. And that's something that our society in general tends to turn a blind eye to, but when people are having sex, they're at risk for HIV. And when people in a community or population are having sex and they don't believe that they're at risk for HIV, then we face a double challenge. And so we tend to look at our very young teenage population as not at risk for HIV, and we tend to look at our older population as at not risk for HIV. We tend to reserve risk for those historically high-risk populations, such as injection drug users and men who have sex with men, and not provide the same level of preventative services to those who are not members of that population. So I think it's important that we embrace this recommendation and provide routine testing and screening and recommendation of testing and screening for all people between the ages of 13 and 64. Obviously, at the clinical level, you've got to balance that recommendation out against the cost. Providing testing to everybody that's being seen may be cost prohibitive, especially if you're working in a smaller rural clinic and you're seeing where you have a high client load. So in those cases, I think it's extremely important, especially those using electronic health records, to establish a flag in the health record systems that can immediately notify the clinician if this person has received an HIV test before, or if a high-risk behavior that's been identified during a history might trigger a new test. Other barriers to HIV testing include confidentiality concerns. The stigma of HIV that still exists makes confidentiality a heightened concern. There are fears, especially in rural areas, where people might know people who work at the clinic, might be related to people who work at the clinic, might work and interact with people regularly that they might be seeing in the waiting room. And so confidentiality concerns are serious barriers for people to access the testing. And at the individual level, people might just have a fear of knowing their HIV status, and that really is kind of denying, it's a form of denial. They don't want to accept that the high-risk behaviors that they know they've engaged in might have placed them at risk, and that they might actually be living with HIV. So even if they have the knowledge of HIV disease, infection, and transmission, even if they've experienced those symptoms, and even if they can link that system with acute HIV infection, there's not a willingness to confront the possibility that they're living with HIV. And once those symptoms go away, that just reinforces their denial, because again, those people will feel healthy and they will feel quote unquote fine. There has been a push within the last 10 years to move HIV screening into non-traditional settings, and this has actually been extremely successful. Settings like emergency rooms, emergency departments, dental offices, pharmacies, and outreach settings where we have groups moving into bars or parks or health fairs, sports tournaments, school events even, any of a variety of settings where they can access not just people at high risk, but all people, have been very, very successful. We're actually seeing more and more, not just HIV, but sexually transmitted infections being diagnosed by general practitioners rather than our traditional STD clinics. So that speaks to the success we've had in moving HIV into non-traditional settings. Some of the challenges we find with this practice, and these are challenges that might be encountered in substance use treatment and prevention settings as well, is there might not be any readily accessible resources for people with a reactive test. So there might not be any individuals present that have been trained to provide that immediate counseling. There might be minimal provider-patient rapport, especially if this is happening in an outreach setting where the individual has spoken with the provider for all of 5 minutes, 10 minutes before they've received a reactive test. Then there might not be sufficient rapport or trust built up with that individual to help support, the linkage process. Obviously, confidentiality, reporting concerns, and then limited time with the person to really work through any counseling or behavioral needs. However, this is a prevention emphasis, and as I said, it has been highly successful. And so more and more efforts, particularly at the state level, are going to be funneled into conducting HIV testing in non-traditional settings. I'm going to talk real quickly about HIV treatment. Treatment has become increasingly important in this day and age, as research over the last 4 years now tells us that antiretroviral therapy, or ART, not just disrupts the life cycle of HIV virus in a variety of different ways. It'll disrupt the life cycle of the virus at different points in its replication process, ergo lowering the viral load, but that it also supports our body's own immune function. So it's not just going in and attacking the HIV virus, but it's also doing what it can to support our own natural ability to fight off the virus. As far as treatment is concerned, individuals living with HIV should consult an infectious disease specialist to talk about their treatment options, which range from 1 pill a day to a combination. And the particular treatment regimen prescribed will depend upon the individual's virus, whether their strain of virus has any mutations that cause it to be resistant to one treatment or another, and it will also depend on the disease progression in the body. It is recommended now that people begin treatment as soon as possible, and research has shown that individuals who start treatment as soon as possible after or earlier after diagnosis do live longer and have more successful results. There are adverse effects to the variety of drugs, and each of the drugs will have a list of different side effects. GI intolerance is a very common side effect, and so upset stomach, nausea, as well as diarrhea are things that many of the HIV drugs produce. Fatigue, dizziness, especially initially as your body becomes accustomed to this drug in your body, you may be experiencing these initial symptoms. There are now, the drugs that are being prescribed more and more commonly now have fewer and fewer side effects. And doctors will work with their patients to manage these side effects and to ensure that the treatment regimen prescribed aligns with this particular individual's lifestyle. And with so many different options available, this is a benefit to the patient. When we look at HIV trends, there has been a significant shift within the last 3 years of how we're dealing with HIV domestically. We're talking about high-impact prevention nowadays, and that's creating and diffusing programs that maximize the reach and the cost-effectiveness of all of the strategies and activities being put forth. So we're integrating programs. We're moving away from siloed programs. We don't want to speak to just creating or funding a program that's going to target only Hispanic Latino people between the ages of 13 and 18 living within this zip code. We want programs that are going to reach a broader population with specific targeted programs reaching the highest of the high risk. So this is what we're calling scaling up. We want programs that can be scaled up easily and effectively to reach the largest number of people. So we're going to see programs like condom distribution, which are easily scalable. Programs like social marketing, which are easily scalable. And we're going to see a decrease in programs that historically have been funded and supported, such as group-level interventions. And so we're really moving past the days of recruiting 9 to 10 people who are at some level of risk to engage in 5 to 8 group sessions, 1 session per week, to address their individual risk. Whereas the science has shown that those are and have been effective, they are not cost effective, and they are not moving quickly enough to impact the level of new infections annually. So those level of interventions are going to be reserved for the highest of the high risk, but we're moving more into programs that can reach more people and have been scientifically proven effective on a broader scale. And that includes more biomedical prevention methods and less behavioral. Some of the biomedical prevention methods include treatment as prevention. Research has now shown that there are additional values to people living with HIV being on antiretroviral therapy, or ART. Having a reduced viral load significantly decreases the likelihood that a person living with HIV will transmit the virus to their partner, either through sexual transmission, drug-related transmission, or even mother-to-child transmission. And we also now know that a person who is not living with the virus can take HIV medicines, and that this has a significant protective impact on themselves. And so a person not living with HIV can take HIV meds, and should they be exposed to the virus through whatever route, infection is less likely to take place. That is being called pre-exposure prophylaxis. We're seeing a lot of linkage to care, structured programs springing up across the country. And these are programs that move people quickly and systematically from diagnosis into the healthcare system. And so on a behavioral level, that's working with them around their own fears and perceptions of the healthcare system and of living with HIV, helping them and assisting them work through the administrative barriers that might exist, whether that be insurance, whether that be Medicaid, whether that be Ryan White, ADAP, and also navigating environmental barriers such as distance, geography, evaluating which doctors are available, or even transportation. So a Linkage to Care program is a one-on-one program with a counselor or provider to work with a person newly diagnosed with HIV to move through the behavioral, administrative, and environmental barriers to get them into stable and consistent and high quality medical care. A linkage to care program may not be required for all people. Some people may be ready and willing immediately to move into the healthcare system. Other people might require this manner of assistance, which is short-term. A linkage to care program could last anywhere up to 5 weeks. Any longer than that, and the person might need to be evaluated for more significant counseling needs. A lot of the changes we're seeing in HIV prevention and treatment are being driven by what is called the treatment cascade. And Ed Gardner and his team provided the research and published the research on what's being called the treatment cascade. And honestly, it's common sense. There are a large number of people living in this country living with HIV. There's a percentage of those who know their HIV status, and there's a percentage of those who have been linked already to care. There's a percentage of those that have been retained in care. Of those retained in care, there's a percentage of those that need ART. There's a percentage of those that are on therapy, and then there's a smaller percentage that have an undetectable viral load. Our goal in this country is to move all people living with HIV to an undetectable viral load. We know that's going to be best for their health and quality of life, and that's going to decrease the likelihood of their transmitting the virus to somebody else. That is our treatment goal. So if we have 1.1 million people in this country that are HIV infected, and we only have 209,000 with an undetectable viral load, we have to systematically examine the processes that are in place that are moving people from infection to undetectable viral load. And that includes testing in order to increase diagnosis, linking to care, client retention at the clinical level, the provider level, and availability, accessibility to ART, and adherence to therapy. So these 4 areas are now our trending prevention targets. And again, that is testing, linkage, retention, and adherence. I want to talk a little bit about the sexually transmitted infections. And so moving away from HIV, we're going to look quickly at bacterial, parasitic, and viral STIs. STD, or sexually transmitted diseases, is still a perfectly acceptable term to use, although in the field we're moving more into STI, sexually transmitted infection. But I think everybody on this call knows how quickly we move from one acronym to another. So don't worry if you're using STD, or STD is what appears in in any standing order or policies and procedures you might have at your clinic. There are 3 classes of STIs: bacterial, parasitic, and viral. Bacterial infections are curable, right, through the use of antibiotics. Viral infections are not curable, right? So viral infections such as human papillomavirus, which causes genital warts, herpes simplex virus, HSV, the 3 hepatitis viruses, and HIV. These are all treatable but not curable. Some of the viral STIs actually have a vaccine, and some of the viruses actually end up resolving themselves. And so the virus will be self-limiting, and your body will clear it after a given amount of time. HPV has a vaccine and is clearable, so our bodies tend to handle HPV within one year generally. And there is the vaccine available for HPV is only available for certain strains of HPV that have been associated with cervical and anal cancers. And so it should be said that the vaccine that's currently out there will not prevent all HPVs, but just those that are most associated with cervical and anal cancers. Herpes simplex virus is not clearable, nor is there currently a vaccine. There is a vaccine for hepatitis A and B, not for C, and there is no vaccine for HIV. The parasitic STIs, which I'm not going to spend any time talking about today, include pubic lice, which we call crabs, and scabies, which are small little buggers that just cause itching and irritation under the dermis. STIs is a growing, and I'm going to use the word epidemic in our country. I'm going to show some stats, move pretty quickly through the stats so that we have plenty of time for questions and talk about prevention. But as you can see, HPV, which is, they say, in upwards of 80% of the population is living with one strain or another of HPV or human papillomavirus. Not all strains of HPV cause genital warts. The majority of the strains of HPV do not cause any outward symptoms within our bodies. But they say, in 2008, there were probably 14 million new HPV infections. And you can see it's pretty well split between ages 15 and 24 and those above the ages of 25. Chlamydia being the second most common and the most diagnosed, 2.8 million people in 2008. Again, the burden between ages 15 and 24. Trichomonas, a little over 1 million. This trick is most commonly diagnosed amongst women, and so and you can see that ages 25 and plus, and that's generally because those are the ages of women who are receiving regular care and regular pap smears. Then gonorrhea, herpes, syphilis, HIV, and down to hepatitis B. We'll talk quickly about syphilis. Syphilis, again, a bacterial infection. It's called the great imitator because the outward signs and symptoms of syphilis are often confused with other diseases. Syphilis is passed through contact. In primary stage syphilis, an open sore is created in the body, and I have no pictures, so I'm not going to show any graphic, gory, drippy, bloody pictures, but it's an open sore, generally the size of a nickel or a quarter, with raised edges, that is painless, and it's odd to hear about a painless open sore on the body. But the bacteria will leave that sore and infect any skin that it comes in contact with. And so should a sore exist anywhere in the vaginal or rectal area, especially if it's painless, someone may not know that it exists and can easily transmit that. Penicillin is still easily curable. Syphilis is most easily curable with penicillin, and that is the recommendation from the CDC still. Even with those with penicillin allergies, it's recommended that they be admitted to a hospital and undergo, I'm sorry, the word eludes me right now, but undergo penicillin injections over a period of time so that they can battle off the syphilis even in light of an allergy. Syphilis begins with primary stage. That is the appearance of a chancre. That's when people are the most contagious. The chancre will heal itself, and then anywhere from 2 to 3, 4 weeks later, secondary syphilis emerges, and that is marked by a rash. The rash tends to appear as small red dots on the hand, bottom of the feet. It can appear on the trunk or even on the back. And so just many people actually often confuse that with HIV infection, as a rash can appear on the trunk of the body during acute infection, or even measles. That rash will also heal itself. The person will become asymptomatic and enter latent syphilis. Syphilis will continue to attack various organs in the body, even potentially the brain, lead to what's being called neurosyphilis, and can lead to severe organ damage, blindness, and even death, if left untreated, of course. The statistics for syphilis continue to rise each year, and there have been marked increases in the MSM, or the men who have sex with men community. And that is the top line on this particular graph. And then men who have sex with women, second highest risk population, and then women are the lowest out of these particular groups. And so there have been noticeable efforts to increase screening of syphilis amongst men who have sex with men, especially men who have sex with men that are living with HIV or are accessing an HIV test. A syphilis test is only done through a blood draw, but can be done quickly, and results can be turned around within a day. And so it's important to note that on this table, only new cases are reported and not rates. Okay, so we see the largest number of new cases amongst MSM, and contained therein amongst the white population. The Black African American population is the second largest number of new cases, and Hispanic Latinos third. Again, this does not reflect rates or proportional to population size, just the number of new cases. Chlamydia, the most frequently reported bacterial STI in our country. This is a sexually transmitted bacterial infection. Syphilis we tend to associate with sexual transmission, even though it is contact transmission. But chlamydia is transmitted through bodily fluids. And the majority of people that have chlamydia tend to not show any symptoms. They say up to 75% of people with chlamydia may not display any outward symptoms. If they do have symptoms, they tend to occur 1 to 3 weeks after infection. Those symptoms in women include an abnormal vaginal discharge, of which the color can vary. It could be clear, it could be purulent. There's a burning sensation when urinating. And if the bacteria does spread to the fallopian tubes, there could be some significant abdominal pain, lower back pain, nausea, fever, and pain during sex, and spotting or bleeding between menstrual periods. In men, the symptoms are a penile discharge. Again, the color and makeup of the discharge could vary from clear to purulent to white. Also experiencing a burning sensation when peeing, and a burning and itching around the opening of the penis. And so the opening of the urethra might become red or enlarged or slightly sensitive as well. Chlamydia can also take hold within the rectal canal as well as the throat. And symptoms there would include irritation, itching, and a sore throat. As has been the case for well over 2 decades, chlamydia rates tend to be the highest in the ages between 15 and 24. So amongst our youth and our teen populations, we see the highest chlamydia cases, highest number of chlamydia cases. And looking at the rates, the highest rates exist in the Black and African American community, followed by the American Indian Alaska Native community, and then Hispanic Latino community. And these rates are going to vary depending upon geography. And so you're going to need to look at your own local epidemiology to decide how best to tackle and organize chlamydia screening efforts. We'll see it's pretty well across the board. Our chlamydia rates highest in the South, especially in the Deep South, but obviously in our larger population centers we have higher chlamydia rates. Gonorrhea Very common, more than 700,000 people each year acquire gonorrhea infection. It's also sexually transmitted through the same routes and channels that chlamydia is. And again, 70 to 75% of people may not display infections of gonorrhea. If they do, those symptoms will also appear up to 2 weeks after infection. Gonorrhea infections can appear one day actually after infection, so they will appear more quickly than chlamydia will. The symptoms of gonorrhea mirror those of chlamydia: a burning sensation. The discharge, especially amongst men and women, amongst men and women, tends to be thicker and tends to take on a yellow or green color, whereas a chlamydial discharge would either be clear or is more commonly clear or whitish. A gonorrheal discharge, more yellow, more green. Within men, they may also experience painful or swollen testicles. Women, it's very, very common for women to not show symptoms of gonorrhea infection. But should they, there's also dysuria, pain while peeing, increased vaginal discharge, again, green or yellow. There might also be an odor that accompanies that discharge, and vaginal bleeding and spotting between periods. Gonorrhea could also be in the rectum and in the throat with those same symptoms: irritation, inflammation, general discomfort, and a sore throat. The rates, again, gonorrhea, ages 15 to 24, we say are our highest rates. It should be said that there have been spikes in gonorrhea and syphilis amongst men who have sex with men, and so this tends to be a targeted population, especially in urban areas. But most prevention efforts for chlamydia and gonorrhea focus on youth and teen. And when we look at the breakdown for the rates of new gonorrhea infection, we see the same racial and ethnic breakdown. Blacks, African American population have the highest new rates. American Indian Alaska Natives have the second, and then Hispanic Latino populations have the third highest rate of new gonorrhea infections. And you'll see that the rates in general are significantly lower than the rates of chlamydia, but the geographic distribution tends to be the same. In the East, and a significant number of high rates in our Deep South states. The issue with gonorrhea right now is treatment. 10 years ago, gonorrhea was being treated quickly and easily with a variety of recommended antibiotics, and I just listed one, ofloxacin here. 400 milligrams, one pill, ofloxacin, treated gonorrhea. However, a new strain of gonorrhea was introduced into our country. It is now resistant to ofloxacin antibiotic, so we changed our treatment recommendations to cefixime. Now we're seeing more and more strains of gonorrhea that are displaying resistance to cefixime. And so we have a standing recommendation of ceftriaxone, which is an injection. So not only does the provision of an injection complicate treatment, but it also complicates people's accessing treatment should they not want to get an injection. And the injection just happens to be in the butt. And that doesn't excite anybody anyway. And so with the rapid introduction of new strains, I don't want to say mutation, I just want to say introduction of new strains of gonorrhea in our country, we've had to adjust our treatment regimens and recommendations several times within the last decade. And so there's question marks on this slide because the discussions are already arising about what are we going to do when gonorrhea becomes resistant to ceftriaxone. And I will say that research is underway on several new promising regimens, but these have not been finalized, nor have they been cleared, and nor are they recommended. So currently ceftriaxone is the recommendation, but there is significant concerned about antibiotic resistance in gonorrhea and where that's going to take us and how that's going to impact our gonorrhea epidemic in this country. I'm going to fly through herpes, so to speak. Herpes is a viral infection. It is sexually transmitted. Most people with herpes don't know that they have it. Symptoms are episodic, right? And people are most contagious during those episodes. Herpes diagnosis can only happen through a blood test. And there's currently no cure for herpes. However, there's highly effective treatment. The treatment for herpes includes antivirals, the most common being famciclovir, valacyclovir, and acyclovir. And I've listed those brand names here because I think most people will recognize them as Famvir, Valtrex, or Zovirax. There's not a lot of research about the prevalence and incidence of herpes in our country because it's not a reportable disease. But when tracking doctors' visits, there is evidence that might suggest that it's more prevalent amongst African Americans than non-Hispanic whites. But again, there hasn't been any significant research on the nature of herpes on a national basis. But if we do look at the number of doctors' visits related to herpes, we can see the steady climb from 1966. So let's talk about hepatitis A, B, and C. These are the three strains of hepatitis that are most common in our country. Hepatitis A is transmitted fecally to orally. So that is someone's fecal matter. People will shed the virus through their feces, and if that feces is consumed orally, that's the transmission route for hepatitis A. So that places people in the hygiene field, travelers, people working in the daycare field who might be changing diapers, people who work in the food industry at higher risk. There's also of note that people who are using drugs and men who have sex with men are also at slightly higher risk for hepatitis A. There is a vaccine widely available for hepatitis A. Hepatitis B is sexually transmitted, 100 times more infectious than HIV, and transmitted through the same routes, right, the same bodily fluids generally, except breast milk. What is to note about hepatitis B is that there's also a vaccine available and can be administered in the same injection as the hepatitis A vaccine. Hepatitis C is bloodborne, is more common than HIV, currently has no vaccine. I'm going to move quickly through a couple of slides here on hepatitis A and hepatitis B. What's important to note about hepatitis A is that it's a self-limiting disease. Does not result in chronic infection or significant liver disease, and will clear itself fairly quickly. And so that's there's not treatment that's generally prescribed for hepatitis A because our body can handle it on its own. However, hepatitis B can go either way. Hepatitis B can be self-limiting, and actually more than 90% of people with hepatitis B will recover and clear the virus on their own. However, in our country, more than 1 million people are actually living with chronic hepatitis B, so their bodies have not cleared it. Those living with chronic hepatitis B will be prescribed antivirals and to help manage their liver disease and the disease progression. And there's actually low mortality when related to hepatitis B. Only about 5,000 deaths per year are related to those living with hepatitis B. Hepatitis C, however, produces a large number of chronic infection. It's the most common chronic blood-borne infection in the United States, with almost 3.2 million persons chronically infected. Hepatitis C is transmitted through contaminated blood, the most common transmission route is through the use of injection equipment, all right, that has not been properly cleaned. There is new evidence that suggests that hepatitis C can be sexually transmitted, but it is not as common as drug-related transmission. Those newly infected with Hep C generally remain asymptomatic, or they may have some mild clinical disease. It might be marked by fatigue or loss of appetite, muscle aches, a low-grade fever, but those symptoms tend to appear in only about 25% of people newly infected. It should be said we tend to think about jaundice when we think about hepatitis C. Jaundice is actually hardly ever seen in the early stages of hepatitis C. That's a later stage symptom. Chronic infection is common and develops in 70 to 85% of those living with hepatitis C. And should that be the case, then those individuals will need to seek out treatment to manage their chronic infection to halt the disease progression, and prevent significant liver damage. So consultation with an infectious disease doctor is recommended, and that doctor may not recommend any significant treatment or medication regimen. However, traditional treatment includes currently interferon tends to be the most common treatment, and that's administered through subcutaneous injections multiple times per week, and is also accompanied by antivirals, ribavirin, and some protease inhibitor. Traditional treatment can last almost a year, up to 48 weeks, with significant side effects. And so this prohibits many people from accessing hepatitis C treatment. However, exciting news within the last month, there have been 2 new drugs introduced and 1 new drug regimen that is interferon-free. And so we have cimeprevir and sofosbuvir. Both are a pill taken once a day. And cimeprevir still needs to be taken with ribavirin and interferon. However, sofosbuvir could potentially be an interferon-free combination, so an injection-free combination. And this is exciting news as it introduces obviously new treatment options that are available to people living with hepatitis C, treatment options that doctors now can choose from, and increased accessibility and availability of treatment for hepatitis C. Co-infection between hepatitis C and HIV is a significant issue. People living with HIV and hepatitis C together face complications and significant compounded complications, especially with the treatment for each of the diseases. So HIV increases hepatitis C viremia, whereas HCV increases hepatotoxicity while on antiretroviral therapy. Both may contribute to the progression of the other. So HCV may increase HIV progression and vice versa, and ultimately leading to increased morbidity and mortality. Anybody living with HIV should be screened for Hep C, and anybody living for Hep C should be screened for HIV. When it comes to hepatitis A and B, the focus has been on vaccination. When it comes to hepatitis C, the focus has been on screening. And now we have recommendations from the Preventative Services Task Force that says any baby boomer should be screened for hepatitis C at least once in their life, and increase screening for those engaging in various high-risk behaviors. So we have an increased focus on hepatitis C screening. Look at some of the hepatitis C statistics over the years. It's good to see that since 1992, the number of new cases has slowly declined. and I'm actually going to move through hepatitis C. When we look at risk populations, or at least populations with increased incidence, we see American Indian Alaska Native at the top of the charts, followed by the white non-Hispanic community, and then the Asian Pacific Islander, Hispanic, Latino community, and the Black African American community falling in the 3rd, 4th, and 5th places. I want to open it now. I know we're coming to the end here, but I wanted to open it up for some questions. If anybody had any specific questions about the specific makeup of any of these particular diseases, symptoms, or treatment.
Great, so at this time, if you have a question, please type it into the question chat box on the webinar toolbar. You'll see that if you have your webinar toolbar minimized, you'll want to open that up again, and there's a slot right there for you to type in those questions, and we will take just a couple minutes here, and then we'll return to Robert's presentation for some closing moments before we close off the webinar. And feel free also, those who are listening, to type in questions, over the next few minutes as Robert is making some concluding statements for his webinar. If you have questions, we will take some at the end yet. So if you still wanted to think about some of those questions, try to get them in the next 10 minutes or so before we close up, and we will address them at that point. Okay, we have a question. Robert, would you expand as to what has led to this recommendation of baby boomers being tested for Hep C?
Yes, absolutely. It's actually the historical prevalence of high-risk behaviors during 60s and 70s, youth populations during those time, of returning veterans during those time, and the increased likelihood that during those 2 decades people have engaged in higher risk behavior. And honestly, it kind of just boils down to something that simple. And so those born between, and I can't remember the years because just in colloquial terms we're just referring to people as baby boomers. So those people being born between 1940 and 1953 or so, recommended to be tested.
Okay. We have another question. Are the statistics of this information being provided to IHS?
Oh, absolutely, absolutely. And actually the Indian Health Service now internally has their own hepatitis workforce that they've created. And so Indian Health Service is now going to be doing more around hepatitis screening within the Indian Health Service and urban Indian health clinics. They are well aware of the problem with hepatitis C amongst American Indians, but haven't had the resources to do much about it. And so it wasn't until this last year that this hepatitis C workforce was developed. And so we look to hopefully see more concerted screening efforts in some of the IHS clinics.
Great. Okay, it looks like that is all the questions we have about the presentation. So why don't if you wanted to go through a few more points yet, and we'll take a few moments at the very end yet for questions again.
Okay. So I moved through some of the slides. You probably saw that on the screen. Most of the content was around prevention, and I'd already referred to at some point, behavioral versus biomedical prevention. But I want to talk about substance use providers and the opportunities that exist for talking about STI and infectious diseases in the substance use prevention and treatment environments. Obviously, there are overlapping risk groups. I think everyone on this call knows that. People who are at risk for HIV are also at increased risk for substance use. And so it's a natural fit for infectious disease prevention and substance use and abuse prevention and treatment to work together. However, the roads don't always they don't come together always so neatly. Many substance use programs focus solely on substance use, whereas we have HIV and STI prevention programs that focus both on sex and substance use. And some substance use programs may focus on abstinence and quitting, whereas HIV programs may promote abstinence and quitting as well, but could also take a harm reduction approach. And so, whereas they might be complementary, they may not always be working towards the same goal. But when we talk about opportunities that exist, we have to ask ourselves, why substance use providers? Why are substance use providers now more than ever being tasked to include and to integrate HIV and STI prevention into their own programming? Substance use service providers historically have had more formal training and education and experience with behavior change and with counseling than those working in the HIV field. People working in substance use work with high-risk clients on a daily basis, and so they have a high level of exposure for people also at high risk for HIV. And they have the benefit, quite oftentimes, people are coming to them, whether it be self-prescribed, court-mandated, whatever route, but people are proactively coming to seek out substance use treatment. Whereas in HIV, there's more outreach that has to take place to reach the high-risk communities. Substance use and abuse prevention and treatment services tend to instill a sense of accomplishment, self-improvement, and reinforces the value of health-seeking and health-promoting behavior. And obviously reduces the number of injection drug use occurrences. People living with HIV require HIV treatment. We know this now more than ever. Right? The earlier they start treatment, the better. However, people living with HIV may be hesitant to access those systems that provide the medical treatment. Substance use service providers can be the bridge to HIV care, and I think that they're uniquely positioned to serve in that capacity. People seeking substance use counseling may be doing so through insurance, and so may have already taken some of the initial steps accessing and navigating the administrative barriers. And again, substance use prevention services, treatment services may have the resources to continue to assist people to move through that system. And so when we put it all together, we always have to examine risk and prevention. We have to ask ourselves, what is contributing to risk, and what are the steps that we need to take to bolster our own prevention efforts. We need to look at social and behavioral risk factors. At the individual level, we need to feel comfortable asking and talking about the partners that people have, whether they be drug-using partners, whether they be sex partners, or just members of their own social network. We need to feel comfortable talking about substance use, routes of transmission, the drugs that are being used. And that's what we're comfortable with. But I think in this day and age, we have to begin to talk about the societal level factors, as well as even the physical factors, environmental factors, We know, and the research has been done and we know anecdotally, that socioeconomic status, class, and race all impact drug use and impact HIV and STI rates. So we need to begin to incorporate into our own screening and our own prevention and treatment programs discussions around poverty and SES, around homelessness and living situations, and about access to resources. We need to talk about environmental factors. We need to talk about geography. We need to talk about distance and transportation, because those factors, even if someone has the best insurance available, will inhibit access to prevention and treatment services. We need to begin to peel away these layers so that we can create prevention and treatment programs that will address each one of these, because if we skip over addressing each one of these, then these individuals stand an increased chance of relapse. We need to look at the family roles. You know, in the short term, families can create a support network. They can foster access to health care, especially through expanded ACA. We now have youth up to the age of 24 being covered under the parents' insurance. So it's more important now than ever that families be involved in access to health care. Families can model positive behavior, and they can provide opportunities for dialogue, which is an important preventative step for both substance use and abuse and STIs. In the long term, families can create and reinforce norms that will devilify sex and devilify gender norms that might even reinforce HIV and substance use risk. At the community level, we need to talk about resources and ensuring access to resources. We need to examine social policies that emphasize health and wellness, equal access, and disallows discrimination to access. And communities have the same opportunity to shape more positive norms around sex, drug use, risk reduction, harm reduction, and gender, and encourage sexual and substance use education and prevention programming in schools. And communities still have opportunities to implement syringe service programs and safer injection facilities, even under the auspices of federal bans. However we define community, I believe that communities have the opportunity to impact the susceptibility of our high-risk populations medically, socially, and environmentally. So I'm going to skip these, and my closing comments are going to be on what substance use providers can do. I think at the clinical level, they can begin to include indicators for HIV, STI, and hepatitis C in all assessments, and remove those barriers that we have as clinicians to talking about sex and partners. Include actionable items in any treatment or service plan, whether it be short and long term, that includes HIV and STI and hepatitis C. Include families and partners in counseling sessions, whether they be individual or group, to discuss risk, provide education, and ensure that the families and partners are creating an environment that is conducive to treatment or recovery and behavior change. I think at the clinical level, we need to key into the environmental and social factors that are contributing to risk and become involved, if a person living with HIV, in the Ryan White case management care team and become an integral and stable part of that person's care system. At the environmental level, I think substance use providers can begin to talk about and discuss the environment in which people are entering or re-entering on a daily basis, and talk about what risk factors, what protective factors are present, and what triggers might be present, not just for substance use, but also for high-risk sexual behavior. I think substance use providers can serve as a conduit for information for individuals and families, and even condom distribution is an important environmental step. Medically, substance use providers can become trained HIV and HCV testers and test counselors, and that can happen fairly easily. And they, if not, provide their own STI screening on site, can ensure that that is a resource and service that is readily accessible to those they're providing services to. On the social level, service providers can create programs that combat negative norms, or I should say norms that negatively impact risk behaviors, support programming that is age and gender responsive, and tailor programming to meet the specific needs and that are not just cookie-cutter structured programs, and facilitate insurance enrollment as part of long-term recovery care. With the introduction of the ACA and its continued expansion in the coming years, we had the opportunity to integrate these programs now more than ever with preventative services, including screening for HIV and STIs, as well as hepatitis A and B vaccinations, HPV vaccinations, and alcohol screening and counseling being mandatory services covered under all insurance plans. We as facilitators to healthcare and health promotion have the opportunity to ensure that all of these become integrated. And we begin to tear down the silos that have existed between HIV, infectious and communicable diseases, and substance use prevention and treatment. All in all, we need to remain solution focused, focus on the strengths that our clients are presenting with, addressing the overlapping and intersecting disorders and diagnoses, not ignoring those indicators of cross high-risk behaviors, and acknowledging and providing the support and the resources that are needed for people to change their behaviors in a positive way. I know that I moved quickly through the last 20 minutes of this, but I did want to focus on the educational components of these particular diseases, and I wanted to end with what I think is some important messages about what substance use providers can do in this day and age to ensure that they're addressing HIV and STI risk of the people that they're serving. So I know we're going to open it up, even though we've gone over a little bit of time here, open it up for further additional questions, but I wanted to leave with my email address on this on the screen, and I want everybody on the line to feel free to contact me if they have any questions or comments. And these slides will also be made available to the ATTC should anybody seek to access them through that route. And I want to thank everybody for bearing with me, and thank you for your attention.
Wonderful. So yes, again, we will take questions. If you have a question, please type it into the chat box that is on your webinar toolbar. So we do have a question now. The question is, where can we obtain the latest documented information as to the latest numbers of HIV and other STDs diseases found on the various U.S. reservations? Can you send us an email with the contact information needed to obtain this information for our tribal behavioral health centers?
Yes, let me actually address that.
Sorry, I will just say, as far as sending the information out, we do have the contact information for those who have attended. So if Mr. Foley could share that information with the ATTC, we can send that out to those who have attended.
Let me actually just make a quick verbal comment on that. Specifically, since this comment was asked about, or the question was about reservation-based numbers. So reservations and the tribes residing on reservations are sovereign entities, and they are not required to report their STI and HIV numbers to the same routes and channels as private healthcare providers and federally funded entities. That being said, IHS assures me that most do, even though they're not required, most do. But the reservation numbers are housed within the specific reservations themselves, and they own that data. And so I'm not going to lie, that's actually difficult data to come by. And the best place to locate it would be to actually contact the IHS or tribal clinic on the reservation to see if they'd be willing to provide epidemiology locally. There have been some reports on sexually transmitted infections in Indian country. They're not reservation specific, but that was jointly published by the CDC and IHS. The last report was coming out last year. And the HIV/AIDS program at the Indian Health Service is the best resource to contact for HIV numbers amongst the AIAN population. And so I'm going to put in a plug for Lisa Neal at the Indian Health Service, and she's a wonderful resource. But in general, the reservation-specific data is very difficult to obtain.
Okay, then it looks like we don't have any more questions at this time. So I will just go on with just final instructions. Please watch for our email handouts for this webinar. Attachments will include a CEU request form, a PowerPoint handout, and a link to our customer satisfaction survey. We appreciate your decision to complete our survey, as completion of these surveys allows us to show SAMHSA the number of people served by our webinar. To participate in the GIPR evaluation, please follow the link in the email. We hope you'll be able to join us for the next webinar in this series, The Science of Addiction, The Brain on Adolescence, with presenter Ken Winters on Wednesday, January 22nd. And we hope you'll also join us for our next webinar in the American Indian and Alaska Native Behavioral Health webinar series on January 8th, when Erin Bailey and Josie Raffaelito will present on bereavement and grief. What are the resources related to Native American youth? Thank you very much for your time participating in the session today, and we thank Robert Foley greatly for his expertise and for sharing such a wonderful presentation with us. We hope you all enjoyed this session, and we look forward to hearing your feedback.